Thank you. Yes, it starts here, and we're glad. We're so glad you're here. But as glad as I am, you're going to be even happier that you are here today because you're in for a real treat to hear from one of the premier scientists, physicians, psychiatrists who really is leading some of the research. And that's really what we're all about here at the Center for Brain Health is at Frontiers of Brain Health, inviting the most prominent scientists to bring you leading edge new discoveries that are taking place. My name is Dr. Sandy Chapman. I'm the founder and chief director of the Center for Brain Health and a professor at the University of Texas at Dallas. I've dedicated my life for really the last 3.5 decades to trying to achieve for brain health what's been done for heart health. Every single person here knows what to do to keep their heart healthy. Well, we want you to know what to do to keep your brain healthy. Just to mention a few things, if you're online, this is also virtual. Be sure if you have questions to put them in Q&A. We'll have a little bit of time to answer those. And if you're in the audience, write them down, raise your hand, and we'll move as quickly as we can to get as many questions. I know Dr. Emslie is going to make time because you're going to have a lot of questions. The Center for Brain Health, as many of you know, is a cognitive neuroscience institute, and we want to do the rigorous science to know whether you're 18, 40, or 100, what is it that we know? What simple steps can you take to make sure your best brain years are next year? So now I would like to introduce our speaker. I am so excited and honored to have invited Dr. Graham Emslie. We actually got to work together for about 5 years on a Center for Advanced ADHD Research, Treatment, and Education, and working with him just holds you in the palm of your hand. After working with him, I wanted to refer every single person to him because not only is he know some of the most cutting-edge science, but he also has the most compassionate heart. He is currently a professor of psychiatry and pediatrics at UT Southwestern Medical Center. He holds the Charles and Sarah C. Chair in Child Psychiatry. He served as director for both inpatient and outpatient at Children's Medical Center and Adolescent Psychiatry Division. His clinical focus is on child and adolescent depression, but it really, as we know, encompasses a lot more than that. His research is looking at the efficacy of trials and medications for children with depression, anxiety, attention deficit disorder, and he's also interested in algorithms for how we can make them better. He's written over 200 articles, 17 chapters. He's invited to speak all over the world, but mostly I'm glad that he agreed to come here today to be with us at the Center for Brain Health. Welcome, my friend and colleague, Dr. Graham Emslie.
Yes, it's hard to believe that it's been this long. The last time I came here, this building wasn't here. And we used to just be in the building behind here, so it wasn't exactly a long way to come, one way or the other. But it was great fun working with everybody here and having different approaches. And I think we've become increasingly siloed, so it's unfortunate we don't get to do this more often. So it is a real pleasure to be here and see this beautiful building. I would say new building, but I guess since 2017, it's not that new, but by my standards, new. They moved us to an old building, so goes to show. So what I thought I would talk about, and Sandy told me to talk slowly, both because of my accent and because I tend to talk fast. And if I have a lot of slides, I had 180 slides originally, and I managed to get them down quite a bit, so it won't be that many. But what I wanted to do was to cover, this is just the disclosures. So I first actually came to Texas in '81, and we had our first NIMH grant in 1985. And in that era, we were talking about depression in kids. We were primarily talking about whether it existed or whether it would be the same as in adults. We were looking at sleep architecture in depressed kids in patients versus controls at that particular time. So things have moved along a lot from there to actually even meaning that kids can get depressed and you can diagnose kids with depression. We wanted to look at medication treatments. We look at psychotherapy treatments as well. And more recently, how do you make use of these treatments in in real-world settings. And I'm going to talk some about suicidality as well. One of the main features you'll see is a big difference between a clinical trial, or even if biology associated with disorders, clinical trials, effectiveness trials, and more real-world situations, and what actually happens in the real world. And the gaps are huge in each of these areas still, and I'll try and highlight some of those as I go through. So we have a lot of the research data, we have a lot of the things we know how to do, it just isn't getting done in the real world situation by a long shot. And that'll be kind of an ongoing theme throughout the presentation. So in terms of talking about depression, we're particularly interested in studying depression in this age group because, as most of you know, depression is sort of twice as common in females as males, except around adolescence. So that sort of 2-to-1 ratio changes around adolescence. It's still one of the more prevalent illnesses in this age group. And most of the children, at least we see, have other problems in addition to depression as a diagnosis, which makes diagnosis more difficult. Third, have ADHD, anxiety disorders and depression are common. So it's actually only about 30% of kids have depression as their only diagnosis. It isn't a mild condition in kids, and so it's high relapse rates, impacts school performance, obviously increase in suicidality. Long-term consequences are significant. And treatment, again, should be more towards getting people not just fewer symptoms, but better, and I'll discuss that a bit more later as well. So one of the, starting to talk about what we know about the science part of it in terms of clinical trials. We did the first antidepressant trial here in children's for the second ground, which is in 1990, the year Prozac came out. So we actually used Prozac to do the study. I'll talk about that more in a little bit. And at that time, industry wouldn't support doing clinical trials in kids. And so it was funded by National Institute of Mental Health. I had to buy the medication, and our pharmacy had to create the placebo from the medication because it was just a risk to do pediatric trials. And it's still a problem for us today getting enough information on clinical trials and safety in kids. So we think of depression in this sort of format, similar to what you might see for like strep throat or something, that how do you get people well, remitted from symptoms? How do you treat them long enough in one episode that they stay well from that episode? And if somebody is prone to having recurrent episodes of depression, how do you prevent future episodes in the future? We have a lot of data on acute treatment, very little data on continuation treatment. Pretty much only our site here has that data, and almost nothing on preventing future episodes of depression. But prior to 95 is when I completed the study on Prozac. There'd been only 300 children worldwide treated in antidepressant trials in kids. So one of the issues was just nobody was willing to do research in the pediatric population. And in those days, people were using, so if you're not familiar with medications much, but tricyclic antidepressants were the original antidepressants prior to SSRIs, which came out in 1990. Essentially they had a lot of side effects, but they had been studied some, and none of those medications were shown to be effective, at least in the small trials that were done at that time. To avoid the 180 slides, I cut down all the slides that show the remaining trials, the 27 trials that have been done recently. But essentially, over now 8,000 children have been in randomized controlled trials of medication. And 11 SSRIs, serotonin reuptake inhibitor trials, and 16 non. There are no positive studies in non-SSRIs. People will say what those are, I'll explain later, but it's a mechanism of action the antidepressants use. And there are positive trials with SSRIs, things like Prozac, Zoloft, Lexapro, etc. Overall, the benefit appears to be, from a meta-analysis, that they are effective. But the effect is moderated by age. The earlier study we did was really the only one that showed children to do equally as well as adolescents. So still a debate about children being responsive versus adolescents being responsive. This may be a measurement issue. as well, obviously, and also the permanence of mood states. If somebody thinks, if you're 40 years old and you've had depression, it's come on and you know what you were like for 20, 30 years before that, it's probably easier to see what you were like before that to see whether it's changed. If you're 10 years old and you feel differently in the last 6 months, it's probably harder to identify that as being different. If you've been depressed for several years, it's even harder to know what you're going back to at that point in time. So it's really hard at times to measure severity and measure persistence of mood as part of depression. But depression occurs in kids, and it occurs the similar frequency as adults, and it is similar outcomes. Based on all the medication trials, we currently recommend we currently recommend trying no medication to start, but if that's not effective, the symptoms continue, then we recommend trying a so-called SSRI medication based on those medications. That's different than adults. So one of the things, there are developmental differences in response to medication, and apparently in children compared with adults. As I said, there was no non-SSRI positive trials in kids, So we do recommend an initial trial, one medication, then a same class of medication for the second, and then go to non-medication, different medications after that. It's a whole other lecture on guidelines and evidence-based care and measurement-based care, but essentially to say these are guidelines based on the research. I, as a physician, will start with a third-line treatment as a first-line treatment for some individual patients because I think it might work better. But this is stacking up the evidence from the research and saying this is best we have from this was best evidence first, best evidence second, and third. One of the things that came out of the clinical trials we did over those 10, 15 years was issue of concerns about safety. It's interesting when you do research, you find out things you didn't know, well, I guess you did know, but prior to late 1990s, nobody had clear definitions of suicidal behavior. So what happened was all these clinical trials were being done, and people were reporting events, and they were saying there were suicidal events, or bad behavior events, or whatever. And so what happened, when the concerns in the mid-90s, late 2000s became evident about concerns about activation. So antidepressants in children and adolescents have a black box warning up to age 24 for an increase in suicidality. It's about 2% rate overall compared with non-antidepressants. And so when people looked at the data from all the clinical trials, it became hard to say, well, how did they define it? And so using the Columbia system was developed, and then NIH and the FDA themselves actually did a reanalysis of all the actual data. And this is the reanalysis. The main point about this has to do with that it's not necessarily an SSRI problem, but it's across all antidepressants. So people get confused between things like Effexor or there's a bunch of other different medications have different mechanisms of action, and it applies to all of those, and it may be equally as prevalent in, it's actually slightly higher in non-SSRIs. Because of the way press works, sometimes single medications get the publicity, and so people think, well, that's the medication that causes it. This covers all the medications and shows similar effect across all the antidepressants. I think I lost a few people on that one. Okay, so as part of the black box warning, this was an interesting thing that happened. The FDA initially put out guidance along with the black box warning. They then took it away again because they realized that probably the FDA isn't really in a position to define practice per se. But they said that kids on SSRIs up to age 24 should be seen every week for the first 4 weeks, every other week for the 12 weeks, and maybe monthly after that. And that was sort of a guideline. They took it out eventually, but that was sort of basically you'd have about 8 visits with a psychiatrist or evaluator, which will be treating you over the course of a 3-month period. This is the part about how does research translate to real practice. Well, even at that time, after the warning, there was no change in the practice. And on average, only 5% of people who have been treated in the real world being given antidepressants actually met that, anywhere close to that criteria. And even only about 60% met the adult criteria, which was 3 visits over 12 weeks. So it's one thing to look at research around these clinical trials where people see people weekly, every other week, et cetera, and to know what actually is done in clinical practice when you go see a doctor in our clinic. I run a depression clinic at Children's, and we also do equally as badly. Time to second visits is about 6 weeks. Time to 3 visits in 3 months is probably reasonable, about average. So it's a problem about taking research and then saying, how do you apply it in real world? And I obviously think we need to do better at figuring out how to make research data better match what happens clinically. But we're still a long way away from that. So not to be purely medical and just one medication, we have done trials comparing medication and therapy, specific therapies for depression. There are probably 3 effective types of therapy that seem to be effective for treating acute, moderately severe depression. Doesn't mean other types of therapy aren't helpful for different subsets of symptoms or different components or general support. But essentially, the one we've studied most is cognitive behavioral therapy. And this was the initial acute trial over 12 weeks. It involved multiple sites around the country. Essentially, adolescents with major depression were randomized to either the combination of medication plus therapy. I do at times wish we didn't keep trying to fight against each other. Therapist versus medication, but more combination. But in this case, this is initial treatment, combination treatment versus medication alone versus cognitive behavioral therapy versus placebo over a 12-week period. It turns out that in this particular study, the combination treatment slightly beat the medication alone, in acute treatment. But CBT alone didn't beat pill placebo. How you translate this and put it into clinical practice is another issue. In the UK and in Europe anyway, they tend to require a certain amount of therapy prior to medication treatment. In this country, it doesn't work that way the same way. But essentially, medicine alone was more effective than therapy alone. Leading into that, this is some data from a study we did of treatment-resistant depression. What you're looking at is essentially people at the end of 6 months, this is independent of the treatments they were in clinical trials, whether they remitted, that is, had minimal or no symptoms at 6 months or not. So at the end of 24 at the bottom is the people who had 24, the red line has had minimal or no symptoms by the time at the end of that period. Their mean scores are on the left. The people who went on over 6 months of treatment who didn't remit are the line on the top line, the blue line. The point of this is essentially that is evident at 6 weeks. The trajectory of those groups is evident at 6 weeks. As you can see, this is post-hoc. The question is, can you actually move anybody from the top line to the bottom line with a future? But just taking the data over a 6 month period, you can see that people who are already evident, if we're talking about people having 3 visits in 3 months of treatment, then the chance to actually try to improve the people that I'm going to get well over 6 months tend to pretty much stay that way from 6 weeks. But we don't increase the treatment at 6 weeks, and we don't try to make real effort to get people better at 6 weeks and well, which is this next thing I'm going to talk about. I don't know if that's entirely clear, but essentially it would be nice to, if people get a little bit better, people tend to say, well, they're a little bit better, so we'll decrease the frequency of visits, or we won't add therapy, or we won't do those kind of things. So it makes sense at this point in time to actually start increase the treatment if people are not responding at 6 weeks. Doesn't always work in our system. So we were kind of interested in that, and one of the things we're interested in is not just getting people well, but sort of keeping them well. And this is a study we did looking at adding therapy after a response to medication. So kids had been treated for 6 weeks. If they had responded to the medication, they were randomized to continue just with medication management over the next 6 months, or they were started on therapy. So in this case, the frequency of visits increased at 6 weeks, and they started doing cognitive therapy. And the idea was this would prevent relapse over the course of the next year or 2 years over that period of time. And I think particularly relevant to this, to Center for BrainHealth, is there are some certain features of the therapy that is more, which I think has been a bigger impact. And I wish there was more work being done in this area. So if you're doing therapy with people who have had a 50% improvement in their response to the medication treatment, obviously the core symptoms are less severe, so you don't have to less focus on that. You can still focus on further reduction of symptoms using cognitive therapy. But I think it's a bit like rehab. Essentially, people have been better, but they've been depressed for a year, 2 years at times. How do you get people well, not just better? And that was really the focus of this kind of treatment. So there was a whole wellness and health component of that. And this is something we don't implement well in our own setting, let alone anywhere else. But essentially, if you had an injury and you expect to do rehab or something after that point, if you've been depressed, it makes sense to have some sort of rehab, essentially to get yourself back, not just back to where you were necessarily, because that may not even be possible, but stronger and build up some strengths to help prevent future episodes. So you have some skills for when you have, and the medications don't have much continuing effect beyond six weeks. If you haven't got better by 6 weeks, very few people get better after that. So this is something that has to be done by other means besides medication at that point. So that's the therapy we developed. I'm working with Dr. Kennard at UT Southwestern, who does most of the therapy. So we put large pounds of positive psychology, sleep and exercise, and wellness promotion into that treatment. This came from the resilience literature. They have kids try to identify areas that they're going to work on to try to improve their resilience to future episodes of depression. So did it help? It did. So in this case, the blue line is the medication alone. At the end of 30 weeks, it's about 8 times more likely to relapse if you didn't have the therapy for that time period versus not. So 9% versus 36% of people relapsed. If you didn't have if you just got continued medication visits for the remaining sort of 6 months in a research study, not just in community practice, but was the blue line, and the red line is the ones who got the therapy, 8 sessions at least within that sort of 20-something weeks, focusing on the things I just talked about. What I thought was really interesting in this data was that the effect is still there at 78 weeks. The treatment stopped within 20 weeks or so, that time period. But I think some of the skills that the kids learned during that time period seems to have some continuing effect during the course of the next. The treatment stops, as I say, about 24 weeks. But there's a continuing improvement in decreased relapse rates. Hopefully it's because they learned additional skills at that point in time as they come out of the episode. So relapse rates are lower, but they still continue to relapse. So switching gears slightly, you say, oh, actually not doing too bad. But I haven't finished yet. So as I said, what we often try to do is to take our research situation, and I'm not sure we're doing that well at it. For example, as I mentioned, I do think frequency of visits, measures-based care, things that we do in a clinic setting, applying those into a clinical setting is being harder. So we did some research on suicide adolescents, and I'm actually going to grab a bottle of water. So I don't croak at you continuously. So essentially, in this context, we are looking at kids. Sam and I were talking earlier about where suicide is just related to depression, but we're primarily looking at kids where depression is a feature of the suicide. Or, put it another way, there's a lot of issues about suicide prevention and treatment. In this particular case, what we chose to focus on was people who'd made suicide attempts or had suicide events that occurred, rather than specifically looking at treat a particular disorder or a particular problem that they have. So we looked at whether taking an actual initial event that someone makes a suicide attempt and looking at all the proximal events that occurred prior to that attempt. It's called a chain analysis to decide on the treatment. And we did a study with a multi-site NIH study. This was individual therapy we're trying to look at CBT versus medication combination. Same sort of studies as before, comparing this specific CBT for people with suicide making suicide attempts, with the aim to reduce future attempts. Current rates were around about 40% or so of kids would make reattempts within 6 months. And this involved us and Barbara Stanley from Columbia, who helped develop the therapy, along with David Brent from Pittsburgh and Betsy, who works with me. So we essentially developed an individual-based therapy that was added on to medication management for treatment of suicidal adolescents. Didn't go quite as we expected. If anyone has a question about it, we'll describe later. Essentially, the individual therapy appeared to be helpful in reducing the suicide attempt rates over the next 6 months to a year in these kids. So what we decided to do was to see if we could implement this in a way that was easier to implement in a real-world setting. So at Children's, we developed an intensive outpatient program based on the individual therapy, where you actually had the kids come in and do 2 to 3 sessions a week in a group format, along with parent intervention and skill-based treatments on things we know that are common factors in these sort of analyses. I think in some areas the group intervention has worked better. You can imagine if you have a group of adolescents talking about reasons for living, how to cope with stress, thermometer kind of stuff, so CBT-based sort of intervention treatment. It may work better in a group of adults than them talking to an adult and trying to go over the same kind of things within that sort of context. So we think that therapies within the group therapy they do is effective, at least 6 hours a week of therapy. And again, the risk factors associated with future attempts, and it comes off both the original individual therapy that we had studied before through NIH, and we implemented it. We actually implemented this through our regular funding through Children's, not as a research study. This program is funded by just for a business plan through the hospital. The idea to help divert some kids who come from the inpatient unit or from the emergency room. And it's found to be fairly effective over time. It has therapy, as I said, also families are obviously involved. And one of the things we did also was, even though it's a clinical program, we added measurement into it at the beginning. So even the beginning, now we have over 1,000 kids who have been through the program. But essentially, we have data on the severity during and post treatment within the program. We also contact them 1 month and 6 months after they've been in the program and look and see whether they are still involved in treatment and whether any events have occurred, any suicide attempts have occurred during that period. So it allows us to use the clinical services that we have, and the data from that is kept, and we keep track of that and can ask it various questions. We have a poster at the upcoming meeting looking at resilience. We have a resilience measure in there, and it's showing that resilience also improves. The self-reported resilience for the adolescent improves during the course of treatment. And parents' competency. We have a questionnaire about parents feel competent about the treatment and what to expect when they have a suicidal adolescent, what to do. And that also improves along the course of the treatment. So we're able to measure those things and reassess our programs as we go along with the program. Essentially, this was to fill a gap. Traditionally, more recently, patients have come into the emergency room. They've either gone to a hospital or to an outpatient appointment. If it's a hospital, they tend to stay for a few days, then get discharged, and may have an outpatient follow-up 6 weeks later if they're lucky. And they both get therapy and medication treatment. It's going to take even longer. This sort of fills a gap for that, allows for better assessment, for more thorough assessment. People are being seen weekly, several times a week during the course of treatment. And it's specifically focused on suicidal behavior. So we think it's feasible. We have good retention rates. Allows us to look at some of the factors that relate to future attempts. Girls are more likely to have a future event. It's affected by baseline suicide risk and baseline depression. And for all adolescents, attempts at baseline and higher discharge depression diagnosis. Things you sort of expect. You don't always find things that you don't expect, but at least you confirm things you thought would happen. So essentially, patients can show improvement in these IOP programs. We have low rates of reattempt rate relative in the program. And we usually identify factors in, we've had a lot of interest in sleep. My earliest research was in sleep architecture. And so we have a lot of interest in sleep. Obviously, sleep problems are a large feature of kids' problems, and particularly in suicidal youth and its association with suicidality. So we had a doctoral student who did a study looking at sleep intervention in some of the kids who are in the program versus not. You can do these kind of things within the program, clinical program, which is helpful. Bipolar, borderline personality characteristics, symptoms. So what are we doing now? We're doing a couple of things. One is, I sort of sometimes put it less interesting in terms of more straight science kind of control things. We're still trying to do some randomized control trials. We recently looked at a peptide associated with sleep, and I'll describe one we're doing currently. But also, as I said, we're trying to get to the point of getting how do you take what we already know and applying it. There have not been any really new antidepressant treatments since the mid-90s, so it was that, I don't know how long ago, it seems like a long time ago. And so we have to do better with what we have, and we're not really doing any better than we were doing before. We may be doing worse than we were doing 30 years ago in terms of length of treatment, stability of treatment, having same providers, et cetera. So one of the areas we're interested in is looking at those kind of things. We have a PCORI grant, which is a multi-site study looking at different types of treatment intervention. In this case, is to answer the question I just raised earlier. We have a group of patients we see, I would say over 1,000 who have been treated for suicidal behavior. We want to know if they do any better than the ones who went to the hospital and went somewhere else. And so this grant is for 4 or 5 sites around the country, are looking at patients who come to the emergency room, who go into a hospital versus people who go into an intensive outpatient program. Cincinnati has one, New York, Columbus, Ohio has one. So we've grouped with them to study kids who are coming in these programs and looking at those who went to inpatient and then follow them for 6 months versus those who went to an more intensive outpatient program. It makes more logical sense if we can find the right patients that a more prolonged intensive outpatient treatment would be better than sending somebody in a for-profit hospital for 5 days and poor discharge planning afterwards. I shouldn't say that, it's been taped. Okay, but anyway, it seems better that we can do better than we've been doing currently. And also for the kids themselves, that they don't do that. I'll keep my political comments to limits as well. So the state, in its wisdom here, has also expressed some interest in supporting research. It used to in the past. Our initial treatment guidelines, the state provided support for research projects. We actually developed the original medication treatment guidelines based on similar adult guidelines funded by the state of Texas funding. So currently, they have shown a re-interest in research for whatever reason, and partly because we all know that the outcomes have not been great in recent years with COVID, et cetera. So the current study is going to go up to 10 years. In this case, we're just trying to provide a registry of people who have been treated for depression in 12 sites, 12 university sites around the state of Texas. So Dallas is a node, Austin, other 12 major universities in Texas. The kids are seen, initially evaluated more thoroughly, and then they're followed up, a lot of it virtually, sending questionnaires out and having them returned. and looking at their outcome and trying to also see what treatment they're getting. So we have sort of a baseline idea of what sort of level of treatment are people getting in the community, not just here in Dallas, but also the whole of the state, and how frequently they get measured-based care, which is measuring your outcomes and looking at treatment guidelines. It allows us to answer some other questions as well relative to follow-up. Essentially, to be in this program, you just have to be, they get paid too. It's an interesting issue. I have time? Yeah, I have time. So we pay them, which is incentive, especially if kids are depressed and sitting at home doing nothing. They don't seem to mind filling out questionnaires and getting a Clin card paycheck for it. So they get $200 or $300 or something if they complete most of the assessments over the course of time. So as part of the fact, with the first run through of this, we found that the kids aren't doing that well. I mean, a third have admitted in almost a 2-year period or 1-year period. So we've started to implement a new intervention, a behavioral activation intervention that essentially is 8 weeks virtual therapy that was done by one of our therapists. They're not charged for the treatment, and they're in treatment as well, but this is an additional treatment to try to improve symptoms of depression for these kids. And if they're in this bigger trial, they can also be in the what's called Activate trial. It says what compensation was, $1,000. So then what happens, a couple of the kids are questioning about whether they should get paid to have the therapy. And we had to tell them, no, that wasn't part of it. We think the therapy is worth it on itself. Filling out questionnaires for us for no known gain is one thing, but having therapy is probably not something we're going to pay you for. It probably would be more effective if we did. We probably should randomize those who get paid versus those to attend the sessions versus not. Also, the trouble is the parents also have to be involved, and they don't get paid in either case. That probably doesn't help. Currently in the network, there are over 2,000 kids that we've seen up to a year or so. So we have huge amounts of data. We're starting to get the 6-month and 1-year data following up. We have 280 here in Dallas. This is the therapy I talked about, which you don't get paid to be part of, but you do get free therapy. So, the last thing I want to talk about briefly is another study we are currently doing, which is using ketamine, intravenous ketamine treatment for people who have made a suicide attempt or had a serious sort of worsening of suicidality. So ketamine is thought to obviously be used for treatment-resistant depression where people have failed to respond. Usually the intranasal ketamine you can get for adults, approved for adults. You can get treatment with that. It's more treatment sessions. But anyway, it's for sort of severe depression and shows some improvement, but it tends to wear off over time. In this case, it also seems to have a separate effect somewhat on suicidal behavior itself. So in this particular study, we're looking at treating people who have made a suicide attempt with ketamine or a control treatment called midazolam, which is you can't really give people ketamine IV and have them not know they're getting it, or something like it. So most of the studies use an active control for studies. In this case, it's a benzodiazepine, which probably they still know the difference between ketamine and benzodiazepine. But and there's only 4 treatments over the course of 2 weeks following the suicide attempt. And then the children are followed for 6 months with the idea of seeing whether the rate of suicide attempts over the next 6 months is reduced in those who got ketamine versus those who didn't. So it's a different approach to treatment of these problems. The idea, I think, is that an acute difference over that 2-week period might change how people view the process farther on down the line. And that's the aim of the study. We're having a little trouble with recruiting, but we're working on it. And we may not get to our 264. So we have to change the aims of the study to being more of a feasibility study than an actual study. But this can what we're doing, and so far it's working fairly well in terms of people being able to do it and the outcomes. So essentially, I've covered my 40 years of doing research in less than 40 minutes. Yep, 39 minutes. And there's As I said, we basically have done a fair amount of research. On a good day, I think we've learned a lot. On a bad day, I wonder whether anything's any different than it was 40 years ago when I started doing this in inpatient samples. I do think we have a lot more knowledge and experience and understanding. I do think we're a long way from taking that research and applying it in the day-to-day lives of people who are being seen in the community and being treated. How to narrow that gap is a question which I think we'll continue to work on. In terms of new and innovative treatments, ketamine is one of the newer ones. There are a couple other new treatments, but essentially we've had no, if you put it one way, we have no new mechanisms for treating depression since 1956 or something, when people realized that MAO inhibitors were essentially the initial treatment. We still use the same, we still target the same mechanism of action. But I do think we can do better in terms of getting people well and then improving quality of life and looking better at resilience and looking better at the sort of positive kind of treatments. I think if we do better at identifying treatment earlier and getting treatment earlier, particularly in people who are not responding initially, and getting people and trying to improve that. Obviously, suicidality continues to be a significant public health issue. I do think these more intensive outpatient programs are a more innovative way to provide that kind of treatment than just putting people in a hospital for safety for a few days and having them leave the hospital. So that's what we've done the last 40 years. Thank you all for listening.
Thank you, Dr. Emslie. I'm sure there's lots of questions, but I get to start with mine first.
Those aren't people who could understand me, I'd be questions. I often don't get questions, nobody understands me.
So my question is, you know, as we look at the diagnosis of depression, it keeps going up and treatment is going up. Why is it not getting better? Is it because of what you say, we really haven't made any breakthroughs in depression treatment? What do you explain over the last 5 to 7 years of why the increase is so dramatic across the world?
So even 10, 15 years ago, even earlier, there was a lot of discussion about the rates of depression increasing, younger and even with adolescents. The rate increases when epidemiological studies were greater than could be explained by sort of cohorted mating. As you know, we obviously have high rates of people who have family members who have depression and they have depression. So it's always been thought there's a lot of strong environmental factors that contribute to that. The specifics of those, people have lots of theories as to why that may or may not be. There's no doubt that the whole process of COVID and all that escalated that sort of isolation. I mean, a lot of very anxious kids actually preferred COVID because they didn't have to go to school, interact with other kids, and could hide away for 2 years. But essentially, I think there are those changes. I think the care is more fragmented than it was.
The care is more fragmented.
And there's no sort of continuity of care. We were talking about University of Rochester. One of my old mentors, professors, was Dr. Romano, who his advent to us when we were residents was, you know, the patients are yours for life, theirs or yours, whichever came first. And so there's not that sort of continuity. We're being treated by groups of people and multiple, you know, you could have 5 different attendings see you in the hospital if you end up coming in the hospital.
Yeah,
so you have different people.
I can see that a lot.
And I think life is more complicated for children and adolescents, and that's increased it. Puberty may have some effects that people seem to get young. I mean, puberty increases the onset of depression as well. So a lot of factors. But, yeah.
Social media, I'm just wondering.
Oh, yeah. That's a good
So the question was, how's social media impacting?
So we're actually studying that from
incidence?
this cohort, because we have social media measures in this large 2,000 cohort, and somebody's just written a paper on that at the moment. I mean, all you have to do is look at your own phones and see how many minutes you spent looking at your phone. Which every time I look at mine, I get really discouraged, and put it down for 10 minutes. So I think that that's a whole new area that I think has been huge recently as well. I think John was you have a question?
Mark?
Oh. So I was wondering, this is probably a hard question, if you can estimate how many children and adolescents right now in the United States are taking, you know, some type of centrally acting drug. That's just a guess. And then, but follow-up of that, has there been any attempt to try and design a study that these are drugs that are affecting transmitter systems in the brain that are developing?
Right.
Any sort of attempt or thought about how to think about how they may be the long-term consequences of acting on a developing system before it's fully developed, if that makes sense.
It does make a lot of sense. In both questions, I mean, I think it's some level you're alluding to use of other medicines besides antidepressants for depressed people, because they probably get undertreated. If you looked at the number of people who meet criteria for depression who are actually getting medication treatment, it's quite a few. Stimulants are used a lot more, maybe, than they were before. We clearly have a shortage at the moment of available stimulants. The question impact on that. Most of the data we have so far tends to be the opposite, but it's still like out. I mean, one of our faculty looked at neuroimaging data from kids we treated with fluoxetine on and off of medication, and it normalized brain function during the course of that time. So the idea would be if you didn't have the same reactivity in the amygdala activity you had when you were depressed and not treated, and you improved to more like the normal control group at that time, then that's actually your brain going through a much more normative period. And that's what some of the people believe with stimulants as well, that if you get people's brains to function more normally, it might be better to use non-stimulant treatments. But within that category, the question is, does it actually improve functioning, and that functioning then leads on its own self and improved functioning overall. In terms of neurotransmitters, we do think potentially the reason why serotonin medications work better for depression than none in kids is because serotonin receptors develop earlier, and none of the noradrenergic ones seem to be as effective in kids. So.
Are there longitudinal studies to answer the question of the developing brain if there is an impact? Because wouldn't you have to follow them?
There's a fair amount of stuff relative to ADHD, I think, for the group in Mass General and stuff, looking at that and whether people do better if they take their medicine regularly or given it, or actually take it and function better, and that kind of stuff. I assume they include some neuroimaging in that as well.
I have a question about the study with ketamine. After everything is done, so they just don't have it anymore, are they okay? Or do they have withdrawals, or are they better?
So ketamine, this sort of dosing, it's a subtherapeutic, subanesthetic dose. It's an anesthetic. So we actually work with anesthesia in terms of doing the study. They use it in chronic pain here at Children's as well. The specific intervention wears off within the medication. You're out of your system within a relatively short space of time by the end of the day. Any positive impact it has on your mood or on your suicidality lasts longer than that. With only 4 treatments in the course of 2 weeks, you're essentially getting these sort of intervening treatments and hoping that changes, resets the computer in a way, because it feels a bit like rebooting a computer, and then it drifts off again after that period of time. Now, again, the difference between a study, a research clinical trial, and doing in real practice, as we know from the recent publicity around the guy from Friends or whatever, is people utilizing it in a different way. There's been some discussion in adults because of people's experience using ketamine, even antidepressant treatment, feeling the best they've ever felt. And so there is a bit of a concern that that isn't really just that depression going away, that is, it also impacts mu receptors, which are opiate receptors, somewhat. In this case, there's not a possibility of getting addicted to it or even getting dependent on it, because it's 4 treatments separate out. The question would be, how do people deal with it over time? And if they don't have any availability with us to get it available after that treatment, and they don't necessarily know what they're on. But you're right, now people are using it in the community more. It's a question of how are they going to utilize it, and people clearly are still being very much helped by it, and doing recurrent treatments and giving boosters for depression. And that isn't necessarily a bad thing. I think it's a bad thing if it gets to the point where it's the likability stuff is a problem. And we do these sort of substance abuse questionnaires during the course of these studies to see if there's an increase in overall addictive content.
Great. I have a question from online. How much do you notice depression of children related to alcohol or drug abuse of the parents?
Well, there's a lot of data on that, especially from the Pittsburgh group. Interesting enough, in our samples, and again, it may depend on who you end up seeing and treating at a different point in time where you're treating people at. The number of people we're treating, we tend to have younger children. Our mean age of our kids that we see in study tend to be about 13 or 14. Depression is probably more common in the family history than alcoholism per se. No, it's there. If on the other hand you study children of people with alcohol disease, then you get high rates of depression and other kind of problems, but more probably concerns about ongoing addiction or alcoholism within that group. It seems to run fairly true at that level.
Mm-hmm. Very good. One more, there's another online. Are there any studies on mindfulness and meditation to help with depression in kids?
Not a lot. There's a little bit on yoga.
Okay.
And I was in a meeting recently with people with bipolar disorder. And we're beginning to think a lot of these things as being like a toolbox, having skills that you learn and what fits for the individual person. So if you can get into the meditation and mindfulness, and that's a helpful thing for you, that's a useful skill to have in helping prevent relapse and so on. It's good to have multiple skills within those things. So I think those, I know some people have used yoga as well. People in Houston have been working on that as well. Specifically treating acute symptoms of severe depression as an effective treatment without any other treatments. We've done exercise. We have done an exercise study looking at exercise as treatment, and that was effective as well.
As effective as the drug?
Well, in this case, we had a stretching control. We didn't have drugs.
Okay.
There was no medication, just the exercise.
Okay. And you had a good effect with just exercise?
Yeah, it was good. It was a good pilot study. It's a certain dosage. The dosage is a lot higher than public health walk, 30-minute walk kind of thing. It's a high level of exercise required, but it works.
You just answered my question. I was going to ask about exercise because it seems like that would be such an important and easy solution to implement that, after so much drug discussion, you wonder how much lifestyle changes are being made.
So I have two thoughts about that. One is, so we held a grant to study exercise. We're trying to get it refunded to do more work in the area. Even the first grant was hard to get funded because people didn't believe we could get sedentary, depressed adolescents to exercise. So we did a 12-week intervention. We worked with Cooper Aerobic Center, and so the kids were going there for part of the time. We were monitoring them every week with ongoing actigraph watches and my acute reach system, going over it with them and saying, well, did you really exercise during those times? And we got them to exercise during that time period. So it's feasible. It's not easy for you to pick that particular population, but it's definitely easy. And it was highly effective. Unfortunately, it didn't change their weight. Most of them were overweight. Probably might know that, but the depression was less severe.
So it seems to me RCTs for this population are an ethical dilemma because you're dealing with kids who need help, and we have so much, it seems to me, evidence just out there in the wild. Is it just this need to really have an RCT to support it? But volumes of data may speak more loudly. As you said, it's a messy business in the wild. And is the Amish community, do they have a lower incidence of depression in children? If so, why is it?
Right.
Is just modern society crushing these kids with all the other crap? Kids went through World War I and World War II and other things. They say, well, kids have a tough time these days. Come on, really?
So I think it's an interesting question. It depends on the question you're trying to ask. So what we're really trying to ask, but I agree with quite a bit of what you're saying, but what we're trying to ask in a medication trial, an acute randomized trial, is there any signal for this medicine to have an antidepressant effect in this particular population? We're not trying to see how it works in real-world settings. And we've been unable to do that in about 8,000 kids, 5,000 kids. So that raised another question, and I actually have a meeting in Washington in a couple of weeks looking at, is there a better way to do this kind of stuff? So I think and then secondly, you don't get those kind of studies in Europe as much because they don't have the industry support for doing the studies. So in 1995 and then 2000, the FDA requires every new compound to have, if it's being used in adults, to have a pediatric plan for them to do studies in that. So they have to do the studies required because prior to that, as you saw, prior to 1995, there were no studies done much in kids, and they were done with samples of 30 people per cell and stuff like that. So those questions are being asked. The question really is, you're quite right, is that the best question to be asking? if that's the only end we put the money in for research, is does this medicine, how does this compound have an antidepressant effect beyond decreasing swim time on rats in puddles or whatever they do, to test whether the drug might have an effect. We obviously need the data on safety, and we have over 8,000 kids in trials. Safety in regards to medications being used versus placebos, so that's helpful. But you're right, more and more money goes into that than into other areas because that's where the money source comes from. But it obviously becomes much harder to study some of these other interventions. But it's not impossible to do it. But it is an important thing. But yeah, we faced this problem once years ago. We did the first study showing Prozac was effective. And we went on to do another study, and the belief was, well, we've already shown one's effective, so we have to change the design of the study. So we did a 2-to-1 ratio of drug to placebo, and that just didn't work either. But yeah, it's a different question. And it unfortunately carries most of the weight of the research as opposed to the other stuff.
Yes. Thank you.
My question is about causation. You mentioned before a familial connection, and so I was just wondering, could it be, or have you studied the potential of it being a genetic or, familial problem in that way?
Yeah, I mean, that's been studied quite extensively. There's obviously a component, like everything else, a component of that. The best study was the earlier so-called Dunedin study, which is a longitudinal study done in New Zealand, following people and looking at stresses and looking at matching it to serotonin receptor variants and showing an increase in depression in those, combining both stress and the gene variant as being a factor. So that is a factor. Obviously, living with depression and families with members with depression is a factor. Interesting enough, we've done 2 studies. We did a study where we only evaluated the children of parents who were depressed. So it was the so-called, I forget what the name of the study was now. So every 3 months, we would interview the children, and the parents were in a larger study being treated in adults. And we obviously found, as you might expect, that the kids' symptoms improved as the parents' depression improved. But we also, because we do these randomized trials, we have at one point, we can't do it anymore because they won't let us apparently give questionnaires to parents about themselves without a separate consent form anymore. So we did one where we got the parents to complete a questionnaire before and after their kids were being treated for depression in the trial. And it turns out that the parents' self-reported depression improved, whereas their kids have improved as well. So it's kind of a two-way street in that sense.
That sounds like a happier home for sure. Yes, last question until I get to ask one last one too.
Yes, of course. You mentioned that the study is to test the effects of this medication on depressive symptoms, correct?
Right.
And you also mentioned working with psychiatrists, CBT therapists, and you also made mention to positive psychology. My question is there a state that the child, if the child is in, helps the medication to work better, faster, helps its efficacy? And if you've identified that state, is this where these other factors like the psychology come in to help get them to that place or to maintain that state?
Go Frankie.
It's a good question. There's 2 parts, so it's kind of interesting. I do think that the therapy, that we rather than compete against each other and say therapy against medication, the timing and sequencing of the treatments make a difference. I do think the concept of rehab and getting people better, we clearly see in our medication trials that people don't get that much better. It's groups, but after about 6 weeks or so. In the larger CBT trial, there was improvement in the ones with CBT out to 18 weeks and longer. So I do think the timing of the treatments is an issue. There was an interesting question relative to the exercise. There's apparently one study done in adults where you had the choice of exercise alone, medication plus exercise, or some sort of control group in treating depression in adults. The group with exercise alone did better than the combination group, with sort of the belief that maybe if you commit to one treatment versus, well, I'm taking this medicine and I'll exercise, you don't do as well. But it seemed like the therapy alone group did better than the combination group with the medicine and therapy. Because, well, that's going to make me better, but I'll do the exercise things I'm required to do, but won't do them as thoroughly. So there's probably a factor in that as well.
Thank you. So one last question. So a new challenge for us to work together, and I thought Sarah Lonnie would ask this, but she didn't. So in some of her work, she's a doctoral student, she looked at people in our BrainHealth project that have a diagnosis, as well as those who do not, to look at our SMART training to see if it helped people reduce depressive symptoms and anxiety and stress. And we found that our SMART training actually reduced it equally in both groups. Would you be interested in a prodromal study to see if the incidence of depression, full-blown clinical depression, could be intercepted way before they have to see you?
I don't know how I could do that. I don't see people until they're really sick.
We need to reduce your caseload.
What really interests me about it is we face kids who've had depression over a period of time. And there's been some discussion about whether some develop ADHD after the depression, because it's hard to have residual symptoms of depression. And so we don't do enough in rehabbing people who after had depression in terms of their executive function, things which might have been a function of
To give them
depression.
the skills in life. Like you said, I love what you said about the toolkit. Thank you so much, Dr. Emslie. That was tremendous. You've heard from one of the world's great experts in pediatric psychiatry that's invited to speak all over the world, funded extensively, and I think you can see why. We're really honored that you were with us today. And let me just tell you, you will not want to miss next week either. Next Friday, we have Dr. Matthew Lee, who's going to talk about human flourishing. So we're shifting from depression, stress, suicidality to what is it like to have human flourishing. Don't you want to know? I hope to see you there. And if you haven't already signed up for the great Brain Gain Text Challenge, get out your phone, do this. Every day you will get something. So please join us and make brain health part of your life. Thank you so much for being with us.